Before embarking on discussing the main theme of this presentation, I feel it would be prudent to give you a background of what all is India. India is a very ancient nation located in the Southeast Asia region. It is bound by the snow-capped mountains of Himalayas to the north, the Arabian Sea, the Indian Ocean, and the Bay of Bengal on all other sides. The most ancient texts known to mankind on the different themes of medicine, mathematics, astronomy, and metallurgy, and many others have come from India. These were written more than 5,000 years ago. To give you a glimpse of the diversity that is India, there are 36 states and union territories, 22 major languages, 730 dialects, 13 scripts. India changes every few hundred kilometers with a different geographical feature, different food, costumes, and local cultural practices. You can understand that when we plan something of a policy for palliative care across the country, these local aspects need to be considered in the implementation of such policies. We have beautiful long coastlines because India is a peninsular country. At the same time, we do have snow-capped mountains as well as deserts. Again, it's a land of contrasts. There is more than enough production of food in India, and yet the poorest of the poor inhabit here. We are advanced technologically, but a good proportion of Indians are illiterate and uneducated. We have beautiful architectural structures, and yet a good number of Indians live in slums, especially in the urban areas. There are dance forms and music, cultural know-how all around India, and yet there are a lot of destitutes also in India. Sports that epitomes health is a well-known feature of entertainment in India, and there are very high number of malnourished children too in India. It is for the spiritual depth that rest of the world looks up to India. It has given birth to some of the most practiced religions in the world. To name a few, Hinduism, Buddhism, and Sikhism. There are some others too, which are minor and only practiced in certain pockets of India. Yoga and Ayurveda are the great grand gifts that India has given to the rest of the world. Ayurveda literally means science of life, and the philosophy of care is mostly around natural alterations to a healthy system within the body through diet, through medicines, as well as through various exercises and massages. There are other indigenous systems like Unani and Siddha medicine systems. Ayurveda text even has a separate section written few thousand years ago about poor prognostic indicators, that is Arishta Lakshana, and the esteem of a physician depended on his or her ability to prognosticate well and manage the care of the patient accordingly. The Ayurveda texts also describe family involvement in patient care, just as the modern palliative care concepts suggest us to do so. The Chinese travelers Huangsang and Fa Hien, who came in 600 and 400 BC periods around the era of King Chandragupta Maurya, describes hospices-like institutions providing food, drink, and medical facilities for the very sick and destitute. Even in Mughal Empire, there is documentation of institutions that took care of the very sick in the country. So history of palliative care in India is very ancient. With 1.2 billion population, India hosts 1/6 of the world's population. Most of them are distributed in the rural sector of India. This is another point to be considered when we plan palliative care services across the country. The mortality estimates in India is 7.3 per thousand, which comes to 9.4 millions dying every year. From this visual graphical representation of projected deaths by cause in India, we can see that more than 60% die after a period of illness. Now, if I were a patient from that group, what would I be looking for in terms of access and quality when I need palliative care? I would probably want to be screened and want my care needs to be identified. I would like to have the team define the goals of care with me and take decisions again by shared discussions with me. I would expect the care to be well coordinated with specialist referrals done when appropriate. I would want to ensure that I receive competent care with the palliative care approach throughout my illness or throughout the lifespan if I need that. Also, I would want the care available when needed and where needed, be it at home, at a hospital, at a hospice, community, or in the outpatient unit. Me and my family should perceive sensitivity, empathy, and satisfaction in the care provided by my treating team. Am I likely to have access to such a quality of care in India? Well, it depends. Let's try to talk about this a little more. This is a visual representation of the countries of the globe according to the level of palliative care development provided by the Worldwide Palliative Care Alliance in 2012. You can note that India belongs to those countries which has generalized provision of palliative care services. Does that mean that if I were to fall ill, I would have access to good quality palliative care anywhere in India? Let's look at this question a little more closely. There are 442 palliative care services in India. Of these, the little state of Kerala in the southwest corner of the country holds 315 of them. Which means that if I were to fall ill in the state of Kerala and I need palliative care, there is a very good chance that I have access to good quality care. The Kerala also hosts the 2 WHO collaborating centers. The range of palliative care services available in this little state covers not only oncology issues, but also that related to diabetes, neurological diseases, as well as disability. So I am pretty well taken care of if I were to require palliative care services while in Kerala. What are my chances outside of Kerala? There are 127 centers outside of Kerala too. If I happen to be in Delhi or in any of the state capitals like Mumbai, Ahmedabad, Bangalore, Hyderabad, or in and around Chennai, I'm likely to have access to good quality care because there are wonderful palliative care programs in these cities. In fact, Mumbai and New Delhi conduct the 2 master's postgraduate programs in palliative medicine in the country, the only 2 in the country. Having said that, the access to good program would be pretty poor if I happen to be in most parts of India. A common measure quoted for adequacy of access is that there should be 1 palliative care service for every 100,000 population. Using that measure, India would require nearly 12,000 services for its 1.2 billion population, whereas currently we are somewhere 1/100th of that required for equity in access to care in India. This is the Economist Intelligence Unit report of 2015, where they studied 80 countries in terms of quality of death index. India came 67th in the descending profile of nations. The same study was done in 2010 for 40 countries and India was in the unenviable position of being 40th amongst the 40 countries. A typical scene when a mid-career medical professional, when called in to see an elderly gentleman with advanced cancer, with comorbidities, and who's now having an acute illness, maybe due to an infection or metabolic derangement, or even has oxygen desaturation. Symptom control is usually not the priority, but the initial activities would be revolving around doing the investigations to establish the diagnosis. Many of these interventions are done just as protocol, and it may not be that the results of these investigations would alter the plan of management for that particular patient. While discussing various decisions related to aggressive interventions, the doctor is usually talking about the disease or the organ or a particular parameter. And the language that he uses, such as improving the current status, could probably be a change in the serum creatinine levels or a shift of the saturation levels in that particular patient. Whereas the family understands this communication of improving the current status remarkably to mean that it will have a great benefit for the patient's well-being, and they will be even able to take the patient home eventually at the end of all these tiresome investigations and interventions. Distressful, futile, and disproportionate aggressive interventions are rampant throughout the ill health trajectory of a patient requiring actually palliative care. So, be it an uneducated, poor citizen of India or a well-off, educated citizen of India who has access to any type of healthcare in the country, their needs and priorities are usually undiscussed, and the patient has a very sterile, isolated, distressful, undignified last few days of life. Out-of-pocket expenditure in India is very high, with 80 to 90% of the population paying out of pocket. This has pushed nearly 55 million of Indians below poverty line every year purely due to healthcare costs. Here is an educated, influential Indian expressing his experiences with the healthcare system when he faced his mother's terminal illness in a well-equipped hospital. Parthasarathi Shom is an economist of eminence, and he wrote in Business Standard in May 2016 that he could give no choice to his mother, who pleaded to be taken home. Such was the pressure he felt from the specialist in the intensive care unit to apply the last available biomedical techniques despite the emaciated body in extreme pain. He gives further details of the issues faced and wonders why and where was palliative care? Why is it not available? So, although there are pockets of good palliative care services in parts of India, if we look at the whole country, the access to quality palliative care is poor. In fact, 96% of adults and 99% of children do not have access to essential pain medications, and they suffer needlessly. Can we improve access and quality of palliative care in India? If we look into the causes of death in India, and since many of them die after a period of illness, integration of palliative care into the healthcare system of the country can make a difference in the near future. The 67th World Health Assembly passed the landmark Palliative Care Resolution in May 2014. It recommended its member states to strengthen the public healthcare system by incorporating palliative care as an essential component of comprehensive care available throughout the life course. World Health Organization has taken international mandates to integrate services of palliative care into the healthcare systems of country, and they provide various guides for the countries and program managers to do so. WHO recommends a model of simultaneous action strategies on improving drug availability required for palliative care, capacity building through education in the concepts and principles of palliative medicine, and reviewing policies and reforming those that are required to integrate palliative care in the region. It also suggests to form an implementation framework that is culturally sensitive and applicable to the region to sustain, govern, monitor, and maintain the standards of the services developed in the country. Where is India in implementing the WHO suggested model for integrating palliative care? Let's begin by looking at what India has done to improve the access and availability of essential narcotics that is crucial for practicing palliative care in the country. Essential narcotic medications are controlled substances. India is signatory to the international conventions on these controlled drugs, the most important one being the Single Convention of 1961. The Single Convention directs the contents and the language of the national drug policy. It mentions ensuring of balance. The balance here means ensuring access and availability of narcotic medications for medical and scientific use, and at the same time taking precautions to prevent its diversion, abuse, and misuse. Due to the prevalent global conditions of the 20th century, most countries emphasized its prohibitory clauses to ensure that they are not supporting drug abuse and misuse. To help understand the complexities of the narcotics law in India, it may be helpful to mention a piece of history related to opium as a trade crop in India. The British India grew opium and made huge profits. The need for monopoly and increasing the profits dictated the policy language of the Opium Acts enacted by the British government. This was way back in the 19th century. Now, in the transition between 19th and 20th century, opioids were recognized as drug for abuse, and with the Single Convention coming into the picture, the need to eradicate drug abuse dictated the policy language. Both these components found its place within the new law, the Narcotic Drugs and Psychotropic Substances Act of India of 1985. It had the contents which blocked transport across the different states, although belonging to the same country, that is India, requiring several licenses with expiry dates, each one which had to be renewed from a different bureaucratic agency. The regulatory language also was predominantly very prohibitory, with harsh punishments for even minor errors in the recording or documentation of the controlled substances. I apologize for the busy slide here, but it was to represent the different interlinked contributors to the lack of availability of opioids in India. The restrictive national drug policy, which I just described, with its complex procurement procedures involving multiple bureaucratic agencies and harsh punishments for even minor errors, caused the medical institutions and even medical schools to avoid stocking of opioids in their pharmacies. Hence, generations of doctors passed out doing undergraduate and postgraduate programs in different branches of medicine without any exposure or training in using opioids, especially for chronic conditions. The only exposure that they had was parenteral opioids, which is used for acute conditions like myocardial infarctions or for severe pain of postoperative periods. The misconceptions and fears were very high, even for oral opioids, due to the fears developed due to the complications of parenteral injectable formats of morphine. All this caused very low demand for opioid medications for treating pain. Even the attitude towards treating pain had undergone a change due to lack of availability of oral usage formats, and hence ultimately there was very poor demand and poor availability of opioids for medical use in different medical institutions of India. The graph here shows the morphine consumption in India from 1985 for the following 10 years. You can see the impact that the NDPS Act of 1985 had on the medical consumption of morphine in India. Almost 97% fall from 716 kilos to 18 kilos. Economically, India is one of the major suppliers of opioid substrate to the rest of the world. But the suffering patient in India, in severe pain, had no way to access the analgesic due to regulatory barriers prevalent in the country. New knowledge changes mindsets. And this is what happened even to the drug policy language. As WHO analgesic ladder was announced in 1986, the late 20th century and early 21st century saw opioids to be as essential medications for managing chronic, severe, and persistent pain. And the need to improve access to medical opioids started dictating the policy language. The drug reform in India was not as straightforward. It requires efforts and strategies at different levels to make changes. The work could be said to have begun in the mid-90s with opioid availability workshops conducted across India to make the decision makers aware of the barriers in the regulatory language and ways to overcome them by adapting model rules which were suggested that they incorporate in their own states. Several states accepted the model rules and adapted them, but the field practices did not change. After a decade of work in that manner, the palliative care community decided to put in a public interest litigation on the lack of access to pain relief medications in the country. Thus, the Indian Association of Palliative Care and two persons, one a cancer survivor and one a relative of cancer patient, together filed the public interest litigation in the Supreme Court of India. The respondents to the case were all the state government departments of health and the central government departments of revenue, health, and medical education. The activities related to the public interest litigation paved way in clarifying a lot of regulatory barriers and the ununiform practices in the country and made way for the amendment that came later. Advocacy that was propagated by the palliative care community played a great role in influencing the decision makers at the government and at the different bureaucratic levels. International organizations like Pain and Policy Study Group and the Human Rights Watch played an important role in bringing forth the essentiality of altering the drug policy of India for humanitarian reasons. Finally, in early 2014, the NDPS Act of 1985 was amended. The amendment expanded the scope of the Act to not only prevent misuse and abuse, but also improve the access and availability of essential narcotics for medical and scientific purposes. It also made provision for the rules to be applicable uniformly across the different states of India, so that the complex procurement and the state-wise differences in the implementation could be avoided. It created a new list, a notified list of essential narcotic medications, which would be governed by the amended law. A single bureaucratic agency was identified for every state so that multiple agencies and the concerned delays could be avoided. Overall, this was a very progressive amendment to happen in India. This has definitely laid the foundation for improving access to at least the pain relief aspect in the palliative care practice in India. And I hope that the background was and the story of the changes in the regulations of India was well spent. Even though 2 years have passed after the amendment of the Act and simplified procedures have replaced the old complex procurement system, we still have a long way to go. The bureaucratic agencies continue to be unaware of the amendment and the purpose of the amendment and their role, the changing mandate of their own positions to make improvement of medical opioids. The fear of punishments continue as there has been no change in the clauses related to punishments. The medical fraternity continues to avoid stocking as well as dispensing or prescribing due to lack of training and experience and misconceptions and fears about using opioids. And the central policy still does not have specific measures to ensure that the enacted amendment gets implemented across the country. So the low demand and the poor availability of opioids for medical use continues in the country. This visual representation of countries as per the availability of essential narcotics shows India to be in the severe shortages category, with very few patients being able to access treatment through the essential narcotics for their pain relief. This study was published in 2016, 2 years after the amendment. To give you an idea about the magnitude of the problem currently in the field, let me take the example of a premier institution of the country. The average number of patients seeking cancer care in a busy tertiary cancer center in India would be approximately 300 to 350,000 patients. 70% of patients who reach tertiary level care are in the advanced stages in India. It has been estimated that 66%, that is 2/3 of those with advanced cancer, would need strong opioids for relieving cancer pain for at least 3 months. The average daily dose we can calculate at 72 milligrams per day. With this calculation, the average yearly requirement for patients in a tertiary level cancer institute would be around 1017 kilograms in a year. In contrast, the morphine consumption for the whole country, as reported in 2016, was approximately 300 kilograms. The gaps are truly huge in the field. It is very clear that perceptions of centuries of restrictions have had much more powerful influence on the professional community than the modified substance of the law. Here again, education can probably be the key to changing and altering the attitudes of medical professionals. The communication of the transitions in the central regulatory language has been difficult in India. The mandate of narcotics control belonged to the Department of Revenue by convention from the British times, and the peripheral functionaries, that is the state drug controllers, belong to the Department of Health. The Department of Revenue needs to go through the chief secretaries of the state to reach the Department of Health. The direct communications or orders are not possible. So despite several national level workshops, the transitions of the mandate, the purpose of the amendment, etc., have not seeped through to the peripheral functionaries in the country. There have been attempts, such as the letter that is seen on the screen, where the senior secretaries from the Department of Revenue have sent communications with the details of the amendment. It will take time in India without the help of local champions working with the state governments and interpreting the purpose and the transitions in the regulatory clauses. Changes in the field are difficult to achieve. Another valuable supportive strategy from the center has been in incorporating morphine and few other essential narcotics into the India's list of essential medicines, both the list for adults as well as that for children. It is hoped that the states use this as a model and include the essential narcotics in their own list of essential medicines, since health is a state subject. Having discussed the issues and the activities to improve access to pain relief in the country, let us move on and look at the other limb of the WHO model for integrating palliative care within a region. That is, the national policy. Are there policies in India that would support the development of palliative care services and its implementation in different parts and with the cultural diversity that I just described in the beginning of the presentation? Yes, the Government of India has formulated supportive national policies for incorporating palliative care into the country's healthcare systems. 2 years prior to the World Health Assembly's resolution suggesting that the member states incorporate palliative care in its public healthcare system, India had declared its national strategy for palliative care way back in 2012. It provided several ways of integrating care into the existing national programs of several non-communicable diseases already being applied across India. 2017 has also seen the National Health Policy integrating palliative care at several levels and dimensions. Right now, there is a debate going on in the Supreme Court of India for finalizing the law for end-of-life care in India and making access to advanced directives as well as end-of-life care for those suffering with terminal illnesses. This was announced in 2012, and in 2016, the National Program for Palliative Care became part of the National Health Missions project for the next 15 years. It envisions that all those requiring pain relief and palliative care in the country should have access to affordable, safe, and good quality care, which is what we are talking about today. These are the details given regarding the National Program of Palliative Care in the website of the Department of Health Services, Central Government. The goal of the program is to integrate palliative care at all levels of the healthcare system. It mentions several objectives: improving of capacity to provide palliative care services, refining the regulatory systems to make available opioids for medical use, incorporating concepts and modules of palliative care into the educational curricula of medical, nursing, and other paramedical courses. It also talks about promoting behavioral changes within the community, altering the attitudes of professionals, as well as developing national standards for palliative care. If the implementation of National Program of Palliative Care comes into being in India, then if I am a patient anywhere in India, I can be assured of access to good quality palliative care. Until today, approximately 14 states out of the 36 states in India have accessed these funds. So the total number of districts covered by the national program as of now are 70 out of the 700 total districts of India. The range of funds accessed have been between 200,000 rupees to 30 million rupees. Most of the accessed funds have been unused. Here you can see that there is a policy document and the field situation is so vastly different. What determines a good implementation within a country like India? I'm reminded of the statement made by Jon Strunsword in his article, The Public Health Strategy for Palliative Care. He says that it will be critical for palliative care experts to spend 40% to 50% of their time educating and supporting other healthcare professionals and the other systems in addition to their own clinical roles. This is, I think, very relevant in India today. Kerala is a clear, practical example of this concept. If you remember, this is the state which has the maximum density of palliative care services in the country. Kerala has several palliative care champions who took it upon themselves not only to provide the clinical services but also inspire their institutions and their localities and the communities, create neighborhood networks, influence the political parties, and influence the bureaucracy to bring changes in practices and making palliative care available in their little state. This success story can be replicated for rest of India if education and its opportunities become widely prevalent. So while the government creates policies, it would be the palliative care champions in the region who will have to work with the community and the governments and the professional bodies and trigger action for change. Again, we come back to requiring a lot of educational opportunities to inspire more champions so that most regions in India have a few people or groups of people who can work and carry on this activity in their own region. There are regions of India where palliative care is completely unknown to medical professionals. Now, coming to the crucial aspect of the recommendation model by WHO, the capacity building or the educational aspects of integrating palliative care into the healthcare system. This also influences all the other aspects of WHO model, the drug availability, policy and implementation, as we just saw. What is available in India as of today? We have post-graduation in palliative medicine being offered in 2 centers, one in Delhi and one in Mumbai. There are fellowship programs, both residential and non-residentials, 1 year as well as 2 years, available through the 6 centers in India. There is a fellowship specifically in pediatric palliative care. There is 1 doctoral fellowship in palliative care being offered at Hyderabad Center of Excellence. There are 6 weeks residential bridge certificate programs for nurses and doctors being offered in a standardized uniform way at 7 centers, and few other centers offer it through their local systems. The Indian Association of Palliative Care, the national body of India, offers essential certificate course, which is more of an awareness creation program. This is being offered at 30 centers and sees few thousands of medical professionals and nurses taking part in it every year. In addition, there are few certificate programs for paramedical workers as well as volunteers in India. These are very few and far. Indian Association also publishes the Indian Journal of Palliative Care with excellent peer-reviewed articles relevant to the culture and practices in the country. It is a free access journal and also an indexed one. The palliative care community conducts several workshops and consensus meeting to develop position statements, minimum standards, or guidelines on usage of a new drug which has entered the market, and uses the Indian Journal for publishing the consensus statement. Since it is a free access journal, all the palliative care physicians who have difficulty in accessing online articles through paid resources have at least this to reach out to. Another valuable contribution of the Indian Association of Palliative Care in the educational aspects of the community is the conferences that it has been holding since the last 25 years. The 25th conference is due on 23rd of February 2018, and it is being organized by the All India Institute of Medical Sciences in New Delhi. I invite each of you to come and attend this conference. It is going to be participated by the excellent scientists and researchers of the palliative care community internationally and at national levels. The centers of excellence, such as the Trivandrum Institute of Palliative Sciences, also ensure availability of learning resources through its websites. Here is an example where the Indian Primer of Palliative Care, which is a case-based learning on the basic concepts and principles of palliative care, is made available free online through this website. There are many other resources, including the policy statements and documents, the minimum standards, etc., available through the Pallium India website. National Cancer Grid is a network of tertiary level cancer centers in India. There are 120 of them connected together through the National Cancer Grid. Recently, it has included palliative care resources into their website, and this can be accessed by the oncology teams belonging to the National Cancer Grid anywhere in India. EPEC, Education in Palliative and End-of-Life Care, is creating a version for India and will be ready, I think, by the next month. Indo-American Cancer Association, that organizes the 6 weeks residential course in 6 centers in India, also have a website studded with learning resources free of cost to those who are registered for these courses. It also provides traveling fellowship to those interested in learning specifics of either palliative care or oncology care. You might have heard of ECO platform, the extension for community healthcare outcomes, using the Zoom technology for knowledge sharing. This is a virtual mentoring platform where a multidisciplinary hub team is the organizer, and it connects virtually to many other centers called as the spokes. The discussion would be both didactic as well as patient discussion. The didactic presentation is usually brief, not more than 15 minutes. Time is given for the participants to clarify and ask questions on the didactic topic. The spokes are then encouraged to present some of their patients where they had difficulties in managing. The idea behind the ECO training program is that most of us became specialists through mentoring and supervised work on our patients. The same principle is being applied, except that this is virtual. The idea is that everyone learns and everyone teaches. The hub team is not considered as the supreme answer to all the issues, because the local problems of the spoke team could be better addressed by another spoke team which is facing similar cultural or local limitations. Here, we try to transfer knowledge and not transfer patients or the provider. It's one of the most democratic and free access to learning that is becoming very popular in the country. Here you can see that the visual medium also brings in the connectivity amongst the group, which sit in different geographical locations, and there is a sense of camaraderie and increasing confidence, because many of them, especially in the remote and rural parts, are isolated in their practice with very little access to academic institutions for clarifying their doubts. There are several ECO programs on palliative care themes happening in India. The one which I depict here is the one conducted from the Trivandrum Institute of Palliative Sciences. The spokes are from across India. Due to the similarities of the socio-political, economic, and cultural aspects, we even have neighboring countries joining in some of our sessions, from Bangladesh, Nepal, and Bhutan. As there is no restriction of cost, this becomes, I think, one of the most vital aspects for educating palliative care in a country like India, with very little resources, both in terms of capital as well as the capacity to teach, and millions waiting to be catered to. How about the standards? To ensure that the new palliative care practitioners who have undergone the bridge training program or a deeper fellowship or a postgraduate program understand the different levels of palliative care programs that they may initiate, a standards audit tool has been designed. The minimum standards requires 8 essential measures to be satisfied and 20 desirable measures. The essential measures include availability of trained professionals, methods to evaluate and document all aspects of care, and uninterrupted supply of drugs. The 20 desirable measures, they look for availability and strengthening of multidisciplinary team like physiotherapy, psychologist, counseling availability, etc. Facility for training in the center, the organizational culture to handle the complex aspects of caring for patients with palliative care needs, availability of research capacity, whether the audits are being conducted to review their own programs, and whether there is enough funding to sustain the program by themselves, and the inroads that have been made into the community by the palliative care program. This is a wonderful tool that is available for a palliative care unit that has been newly formed to assess themselves and aim for improvement. The creation of this tool has been published in the Indian Journal of Palliative Care. I hope you find these references helpful if you wish to know more about the situation in India. To summarize, India as a country has acknowledged the value, relevance, and scope of palliative care as an important, significant, and essential healthcare needs of its citizens. The NDPS Act amendment in 2014 was a great stride towards releasing the millions in pain in India from the shackles of regulatory barriers that kept the essential narcotic medications away from them. Much needs to be done to implement the Act so that finally the field practices reflect these great humanitarian reforms in the policy. The National Program of Palliative Care has seeded several initiatives across the country. Now, finally, the actual access and quality of care through the palliative care sector would depend on the activity of local champions. And these local champions would be evolved through adequate and optimal education in the field of palliative care. They would have to work at the state and union territory levels and activate the 3 limbs of the WHO model for integrating palliative care. That is, they'll have to ensure improvement in drug availability while preventing and misuse in the region. They would have to increase opportunities for education in the field of palliative care, both at the undergraduate and postgraduate levels by advocating the field through the universities and at the level of medical schools. They would have to work with the state governments and help them utilize the funds which have been made available through the central policies. And the entire implementation structure, the governance, the standards, and quality would have to be a collaborative activity between the government, the non-governmental sector, and private institutions. The field of palliative care is growing in India. The non-governmental organizations have always taken the lead in palliative care services and is continuing to grow. The 3 state policies, the one which was declared in Kerala and 2 others, have active implementation processes taking the activities forward in their respective states. So the other 2 states are Maharashtra and Karnataka. There are new initiatives from the state government in Telangana, Tamil Nadu, and Assam, which is looking at utilizing the funds allocated by the center and making it available for palliative care services within the state, going through the government structure from the district hospital, taluk hospitals, community health centers, and the primary health centers. The National Cancer Grid institutions are also looking at incorporating palliative care as one of the important aspects of assuring quality of care within the institutions by a collective approach. The corporate hospitals are facilitating new departments of palliative care within them, appreciating the quality of care and the support that it will bring for their positions in the field. Thus, we see that the government, the non-governmental, as well as the private sector are fully engaged in improving palliative care in the country. All these have been very recent developments, and it may take years or maybe decades to actually see the changes in the field. To bring things in perspective, if I look forward to accessing good quality palliative care when I need and where I need in India in the near future, would that be too ambitious a thought? Well, maybe, but that is when we think from the point of view of the provider. From the point of view of patients, this becomes a minimum mandatory requirement because all of us finally die in the system that we create around us. I thank all of you for patiently listening to this presentation. I hope you have a great conference in November 2017 and wish you all the best. I thank the Palliative Care Network again for this opportunity of making the presentation and some of the little stories of India be heard by such a vast community that is interested in it. Thank you.